We know that 25% of the patients have liver metastasis at the time of diagnosis. 25% will develop liver metastasis during the course of the disease. And what is important, that 2/3 of patients with liver metastasis will die of their liver metastasis. So there is a special weight of the liver metastasis in this disease. Probably the complete synchronous resection, the primary tumor and liver metastasis is rarely possible and probably not desirable if you look at the result at the long term. We are in the typical goat-cabbage-wolf situation. While taking care of the colon, the liver disease will progress. Neoadjuvant rectal radiochemotherapy is ineffective on the liver, and we discussed yesterday and this morning, optimal liver chemotherapy is too radiosensitizing. We do still the primary first when there is a threat of large bowel occlusion, when the patient is unable to tolerate a strong chemotherapy due to the side effects, and when the large rectal tumor with little metastatic disease in the liver, and one is probably perforated primary with fever. For example, for this 54-year-old man with a very huge rectal cancer, probably with, as you see here, I have no flash, okay. There is a small deposit, only a small deposit on the liver, and probably this patient is best treated by pelvic radiotherapy followed by rectal surgery. Our approach, liver first, is liver-oriented chemotherapy first. And this is really a teamwork. From the beginning, we have to speak with oncologists, radiologists, surgeons, and pathologists to discuss about the procedure and each step of the procedure. For whom? For patients with no occlusion, for patients fit enough to tolerate the side effects of chemotherapy. When a R0 resection at all sites, whatever the number of surgical procedures used to reach this goal, sometimes we use 2 stages just for the liver, 1 stage for the lung, and another 2 stages for the rectal and to close the ileostomy. And I want to give you the example of this patient. And this patient, 40 years old, with epigastric pain, had a small sigmoid cancer. We discovered it due to a jaundice. So this is a sigmoid cancer responsible for jaundice. The CA was high. She was KRAS wild type. And this is the CT scan, as you can see here, with a very huge metastasis, 20 centimeters large, with a dilation of the biliary tract on the right and on the left. And it was another metastasis on the segment 6 of the right liver. So probably you will agree with me that to remove the primary tumor is not the best to do for this patient. So what we did, this is an induction neoadjuvant chemotherapy using oxaliplatin and Xeloda with a decrease of bilirubin. And we can continue with FOLFOX Erbitux for 10 courses. And we did a left and right anteroportal embolization for this patient and look at the liver after the chemotherapy and the left and right anteroportal embolization with a very large segment 7, and you see the metastasis. That's the 2 metastases that were left in this moment. So we gave to this patient a course of chemotherapy during the regeneration of the liver. We proceed to a left hepatectomy extending to segment 5 and 8 and a part of the segment 6. And 1 month later on, she has a low anterior resection from the town where she was coming from, and NTN, an adjuvant chemotherapy with 5-FU Erbitux. And this patient has no evidence of disease after 45 months. I wanted to illustrate the reverse approach. Probably this patient benefits from this approach. It's 45 months is too early to say. However, I think it's quite, so far, a good result. So how did this approach become ethically possible? Because the new chemotherapy combinations are now available with a response rates that increase from 16 to 80%. And liver surgery has become a low-risk procedure. I will come back about that. But first, as you see here, with the blue column, with the 5FU leucovorin in the Mayo protocol, we have less than 20% of response rate. Using on the left with FOLFOX or FOLFIRI, the response rate is about 50%. But if you add oxaliplatin and irinotecan each other week, as we do, or this is quite a FOLFIRINOX, but FOLFIRINOX is a little different, we obtain in a Swiss study, multicentric study, of 78% of response rate. It was published in 2005. And now we can add bevacizumab or cetuximab for this chemotherapy, and we have a response rate higher than 80%. However, if we have a very good response rate, we should be aware that after 5 or 6 cycles of chemotherapy, it could be dangerous to continue because there is quite a high morbidity associated to major hepatectomy. So when you have a control of the disease, when the sera is decreasing, you have to go to the, and when the metastases are resectable, you have to go in the operating room. So the ideal concept of the reverse strategy is first a very efficient neoadjuvant chemotherapy, short and strong. This is a message, followed 3 weeks later by a R0 resection of the liver metastasis. Sometimes we need 2 operations of the liver. And 4 weeks later by colorectal surgery or first pelvic radiochemotherapy when needed. And at the end, adjuvant chemotherapy. How did this approach become ethically possible? Because the liver surgery has become also a low-risk procedure. And if you consider what we do in Geneva, we have a mortality of less than 1%, 0.8% out of more than 1,000 hepatectomies, where 452 hepatectomies were major. And what is important, we do 2/3 of the hepatectomy without blood transfusion. This is important because there is a poor influence of transfusion on perioperative and also on the long-term outcome in patients following hepatic resection. For colorectal metastasis, was published 10 years ago. So we have some contribution to the pro-generative strategy because these patients have a huge number of metastases. And when we have a remnant liver less than 30%, we prefer to proceed to a portal embolization. When the patient had a strong chemotherapy before the operation, we want to have 40% of parenchyma. When the patient has deposit on the left lobe, what we can do, this is in the same time of the percutaneous portal embolization, this is a percutaneous radiofrequency of the lesion. And if the patient has multi-bilobar liver metastasis, we prefer to do a 2-stage procedure. We do not do HALPs because it's dangerous with a very high mortality. This was reported so far. And we do not do interval chemotherapy. So we try to have 4 to 6 weeks between the 2 hepatectomies. How we do it? We do conservative radical metastasectomy using the sling technique, as you can see here, and we control the margin because the margins are very important. The first operation seems to be easier than the second one, but it's wrong. The first one is more important. It's difficult to obtain because there are 2 aims. The first, to have clear margins for every metastasis. The second, to have enough parenchyma for the future, because this will be the liver left in place. And for example, here we have a depth control by ultrasonography with metal clip to control how deep is the metastasis. For example, here you have the left hepatic vein, and this is important to keep this vein because this patient will have a second step, extending right hepatectomy, removing the right and the middle hepatic vein. So this patient will have only one hepatic vein, and this is this hepatic vein. What are the advantages of this reverse strategy or primary first? This is a high-impact chemotherapy on liver metastasis with about 80% response rate, and we want to control the disease before to operate on the patient. Removal of all cancer tissue from the liver before to do other procedures. And this highly effective chemotherapy impacts also on the primary and so on the lymph nodes, but the response rate is less, about 60–70%, no more. However, I want to show you this patient with 9 synchronous liver metastases from a rectosigmoidal adenocarcinoma. You have here some liver metastasis, and here you have a very large sigmoidal tumor. It was interesting because this patient received OCFL and bevacizumab chemotherapy, and with this chemotherapy, we were able to turn a clinical T3 N1 M1 into a Y pathologic T0 N0 M0. And this is the histology we obtained. You see that for the colon there is only a scare. For the metastasis, there was a fibromyelin transformation of the metastasis, and the lymph nodes, you can see also the fibroinflammatory reaction of the chemotherapy here. The patient was N0, and as expected, he is alive with no evidence of disease after 7 years. So one of the questions is the morbidity of stage prostatectomy, when you do the prostatectomy after the hepectomy, increase or not? And they did it in the MD Anderson, where they used the reverse strategy. And the conclusion were that risk factors for morbidity of stage prostatectomy are similar to those for standard prostatectomy. And in selected patients, the reverse approach, prostatectomy is safe with acceptable morbidity. In our center, it's possible after the hepatectomy to do laparoscopic resection for the colorectal cancer. What are the rationale of the reverse approach? There are some practical considerations. If you consider the colorectal surgery, you have on the right the anatomic leak that we can find. And for the rectal surgery, usually we have between 5 and 12% of leak. The problem, and with the morbidity, that's usually an infectious problem, that this avoids the patient to receive chemotherapy. And you know probably this paper better than I do from the German Rectal Cancer Study Group, when they randomized 800 patients assigned to receive preoperative radiochemotherapy or postoperative radiochemotherapy. Look only at the number in yellow. Before the operation, 9 out of 10 patients could receive the full dose of radiotherapy. But whatever the reason, after the operation, only 1 out of 2 patients received the full dose of chemotherapy. We know that neoadjuvant chemotherapy increases the resectability rate. We know that neoadjuvant chemotherapy, in this case, a conversion chemotherapy, allows to spare liver parenchyma because we can decrease metastasis. Sometimes do only a segmental resection of a radical metastasectomy more than an hepatectomy. They can select responders versus non-responders and probably increases the long-term survival after colorectal liver metastasis resection in patients with several metastases, provided that the patient can have it. And this could be the problem. And look at this paper. It's interesting, published last year. It's monocentric retrospective. However, the title is Postoperative Complications in Patients with Rectal Cancer are associated with delays in chemotherapy that lead to worse disease-free and overall survival. And if you look at the curve in blue, you have the patient who have the chemotherapy within 8 weeks. And in red, the patient who were unable to have the chemotherapy within the 8 first weeks. Do you have the difference? What is interesting, look at the first year, there is no difference. But after 50 months or 100 months, you see how is the gap and how large is the difference. There is also theoretical consideration to the liver-first approach. We know that rapid growth of metastasis after removal of the primary tumor has been described in several mice models. And the primary tumor is supposed to inhibit angiogenesis of the metastasis. You have some papers here. And what about the human being? This is Theo Ruas that with his group published that vascular density in human colorectal liver metastasis increased after resection of the primary tumor. And that the increase of vascular density had a positive effect on the growth of the colorectal liver metastasis in humans. The relevance of this phenomenon in a clinical setting is still unknown. However, the same group published that they observed that there was an increased metabolic activity of indolent liver metastasis after resection of primary colorectal tumor. They have an experience with a group R doing a PET-CT scan in patient before primary tumor resection and 3 weeks later on. With a control group, with a PET-CT scan as a diagnosis, and about 3 weeks later on without operation. And they observe a higher metabolic activity after surgical resection of primary tumor that may have direct clinical applications. One of them could be the primary liver first. I want to illustrate the reverse approach about our first case. This was a young lady, 54 years old. She had a consultation for diarrhea. At colonoscopy, she had an adenocarcinoma at 8 centimeters from the anal margin. The tumor was T3 at echo endoscopy. The CA was more than 200, and she had 3 huge liver metastases, and you can see here. So I think that an upfront operation cannot be recommended in this case. So what we did, but it was last century, we did the first case with OCFL chemotherapy, and we were surprised after 4 months, the patient had 4 courses, that the patient at endoscopy has quite normal tumor. And after 1 course of chemotherapy, normal rectal symptoms. So what to do at that time? Because we have a decrease of the metastasis. And we were afraid, if we want to care of the rectum first, that the liver metastasis will grow again beyond the possibility of cure. So in this case, we thought that it was better to start with the liver. So we removed the 3 metastases from the liver, and we did an infrared pelvic radiotherapy before the low anterior abdominal resection. What was interesting, because it was the first case, that on the histology, there was mostly scar tissue with viable tumor cells in the periphery. As you see here, this is a GLG3 with viable cells in the periphery, and in the center, you have a fibrohyaline transformation. On the rectum, there was only an ulcerated scar lesion, but there was microscopic island of residual adenocarcinoma and 1 focus of perineural invasion, despite the fact she has neoadjuvant chemotherapy plus pelvic radiotherapy. However, this patient has no evidence of recurrence after 14 years. Now, the result that we obtained with a reverse strategy using chemotherapy first, liver resection second, and primary tumor resection third in 58 patients with non-obstructive colorectal cancer, 50% had rectal tumor, and 50% were initially non-resectable. The median number of metastases was 6, the mean 7. The median size was 6 centimeters. The metastases were bilobar in 70% of the patient, and 11% had lung metastasis. And 50 patients, this is 86%, who completed the program, had an overall survival of 62% at 3 years and 48% after 5 years. Remember, this patient has 6 metastases, 6 centimeters growth in median. 8 of these 58 patients had no resection, and with 6 deaths within 12 months because they did not respond well to the chemotherapy. The lesson we have learned during this experience, these patients are very sick and cancer is likely to recur. We have to think about recurrence from the beginning with a conservative radical hepatectomies. And the chance of a cure in this patient is dictated by good timing. All steps should be scheduled in advance. It's very important to have a perfect chemotherapy, a perfect liver surgery, a perfect pelvic radiotherapy if needed, and a perfect, of course, rectal surgery. In conclusion, the liver-first approach for patients with advanced synchronous liver metastasis allows to downstage the colorectal metastasis in 80% of the cases, to select patients with non-responding disease in whom to avoid a futile surgery, and to deliver state-of-the-art preoperative rectal radiotherapy without the fear that liver metastasis will meanwhile progress beyond the possibility of cure. I thank you for your attention.